What about Elotuzumab, Harry? Where do you use that?
I tend to use Elotuzumab in especially just one setting, where a person is on lenalidomide maintenance, either post-transplant or non-transplant eligible, and biochemically their numbers are going up, but they feel exceptionally well, and I just don't want to wait on that disease. I try to get more mileage for the lenalidomide by adding in Elotuzumab and going up on the lenalidomide, and it works in some cases, and it might prolong the next big regimen that we have to use.
Noopur, are you using Elotuzumab?
So using Elotuzumab less and less. I think it's hard to find a place for Elo. I do think Elo is a drug which should be used early on in the disease and probably as a maintenance strategy the way Bob is using it in his trial. We just don't have the data to speak to that just as yet. But my patient who is somebody I'm treating with LEN with a low risk relapse would be where I would add Elo.
Is everybody in agreement with that? That's the general use of Elotuzumab?
I mean, there were upfront studies with Elo-based combos. Through SWOG, we did a combination with Elotuzumab, Len, bortezomib, and Dex versus RVD for high risk, and we don't have the data yet because they haven't really read out yet.
In relapse or in newly
This
diagnosed?
was frontline.
Yeah.
And there was actually an abstract from Jacob Lawback at this meeting looking at Elo RVD frontline, which was actually a little concerning because there were quite a few infections, probably because of the lymphocytopenia. So it's definitely a regimen that one has to be careful about, and I'm not sure about its role in the upfront setting at this point.
Do you think we'll use, if people are getting daratumumab in the frontline setting, do you think Elotuzumab will be a antibody we use at relapse, or do you think we would retreat with daratumumab?
I think we retreatment with daratumumab. I was actually waiting for the results of their study in the maintenance. I was very interested to see how the high risk behaved with the addition of Elotuzumab after transplant. So that would be interesting, rather than combine with a proteasome inhibitor going with the Elotuzumab. But I think in relapse, I will go ahead and retreat with the daratumumab.
Anybody in patients who are on daratumumab and they're beginning to progress, is anybody changing the schedule? I've heard this bandied around as one strategy. Noopur?
You know, I think all of us have done that because...
And describe what you do for the audience.
So typically what happens with the DARA-based regimen is you give weekly DARA for the first 8 weeks, then you go to every other week for the next 4 months, and then you go to monthly. So if somebody's progressing on monthly, I have gone back to a more intensive DARA regimen, which is either start off weekly or sometimes every other week. And we do recapture responses in that. Again, those may not be long-lived responses, but we've done that.
Harry?
I do exactly the same thing, and then there is probably data that are coming soon about drugs that can increase antigen expression, including things like cyclophosphamide at low doses, metronomic doses of cyclophosphamide, ATRA.
When you treat your patients with, let's say, daratumumab, pomalidomide, dexamethasone at relapse, is your plan in a younger patient to use a second transplant, or are you using that as a sort of risk-adapted, depending on the response strategy? Christina, do you retransplant people?
Depend the duration of the first remission, and I think our cutoff was 18 months, 24 months. However, now with the maintenance, I think we need to revisit that cutoff because we see even the high-risk patient going longer. And so if they're going to benefit from a second autologous transplant is unclear to me yet. So we need to revisit that in the transplant world. But yes, if I have a patient in remission for 4 or 5 years, I re-challenge with another transplant, kind of reset the clock in that way. What is confusing right now is what we do in the maintenance in that situation, right? Are we going to go with the pomalidomide? Are we going to go back with the pom-dara? So is the transplant allowed in us to achieve the depth and then continuation? So a little bit of confusion in that setting.
Bob, what do you think about second transplants?
I agree. I think it's reasonable in people who've had a good benefit from the first. There are data now from MD Anderson from a randomized study comparing just melphalan alone as a conditioning regimen to busulfan with melphalan,
let's talk
which
about that.
may be better in terms of efficacy, although it has some toxicity associated with it. So if we retransplant folks, we often will do a combination conditioning regimen like that. I did want to briefly go back to this question of retreating with DARA, because before we as a panel anoint that as a standard of care, there are absolutely no rigorous data to prove that continuing this expensive drug, which over time reduces CD38 expression on the myeloma cells, is of benefit. What you would need to do is, for example, if you progress on dara-len-dex, compare in a randomized fashion bortezomib-dex versus dara-bortezomib-dex. Literally, we have case reports now. So I actually don't continue DARA if patients do progress on DARA.
Yeah, thank you for bringing us back to reality there, Bob. I actually completely agree with you. We have this notion that going back to weekly is somehow magical, but we really have no evidence that this is the case.
Yeah.
Right?
And I agree that we should actually follow it up with CD38 expression. If it is, and strategies to improve CD38 expression might be the way to go.
But it could also be that some kind of T cell, NK cell, macrophage exhaustion is the mechanism for resistance, in which case coming in with another antibody that depends on ADCC may not really be of benefit.